from one to the other, and so that's one of the things we're going to do. We need to have a person be, we'll actually have a person be the victim, because I will instruct the victim on how to act. So is there anybody here who's ever appeared on Bollywood Idol? Is there anyone here who's actually been on television before? Many of you look like television actresses to me. Alright, so we need to have a person who can act, and I think it should be you. It's one of our faculty persons. This is the responsibility of being a faculty, so lay down on the table. Can we put a pillow? Can someone give their Joel up to put on a pillow? I'm choosing you because I think every faculty person is automatically an actress. This way. Right, now I need the first team of 5 to meet me outside. I think you guys are the best. I don't want you to tell them that I said that because they'll be jealous. Now, do you have a copy of the papers with you? Excellent. So you may want to think about how you deal with chest pain. And now I'm going to go in there and instruct the victim and everyone else what we're looking for. And you can spend a minute or so discussing it amongst yourselves before we call it. Okay. That's all I'm going to tell you.
They monitor and
So what they did was they rushed in. They actually changed her position, which actually wasn't in the script, but that's good because if they're having a little bit of CCF, that'll make their breathing better. So that was good, and all that. If you have a person who is obviously having MI, when they said, oh, hook him up to the monitor, but no one turned and said, what does the monitor say? So you need to do that. Well, they should ask me, because then I'll tell you. But then you gave the morphine, you gave it all like morphine, oxygen, nitroglycerin, aspirin, boom. And then she was better. So that meant you were really thinking it. It meant that cup of chia that you had, that was strong chia. So now, here's what we have to do though is, then I was there saying, then what? Then what? Then what? Because when you stabilize them and they're feeling better, that does not mean it's over. What that means is we got to get streptokinase and reperfuse. So it's not over until they've done the reperfusion, and that, you know, these are all partly measures. So we do that to help the person get through the first 5 minutes. It's not over till we get to reperfusion. What is N equals M? Okay, so just because you fix them doesn't mean you can slow down. It means you have to go get the stuff. So there. All right, so now next team. You're a really good actor. You mentioned that because I was going to tell you, I've been watching you guys. I actually think you are the best group. But I don't want you to tell the others how to sleep. So I'll be jealous. So now we're going to start with bradycardia. We're going to have a person who has terrible chest pain. Just like that before. It might be a little different kind of MI than what we just had. So, think about the coronary syndromes and all the other things that we've gone over already. Give you a few minutes.
Oxygen start especially iodine folate example iodine folate aspirin or aspirin the oral oxygen भयो nitroglycerin भयो IV कले oral यो मैले के भने यो के डायग्नोसिस भने के डायग्नोसिस भन्नु भने हेल्प भन्नु अनि के भन्नु अनि एउटा बीपी अनि एक्टिभ हामी गर्नु बीपी सर्भे डेफिट स्टेप्टोकाइनेस पनि दिन पर्छ दिनले दिनु पनि सर्भे भन्दै जान्छ दिनु कन्डिसन सर्भे डिजुरेट राम्रो भयो भन्नु भएपछि डिजुरेट भयो सिपिआर माथि गर्ने लिजाउने मोनिटर गर्ने त सिपिआर हेरेर आज मोनिटर माथि गर्ने मोनिटर गर्ने
Blood pressure is 70 by 40. Her blood pressure is 70 by 40, and when you put her head up, she goes dizzy and gets unconscious. 70 by 40. 48 beats a minute. Monitor says 30 feet block, 48 beats a minute. Working out. That's a good idea, but might not have spoken up. So don't get carried away into we've got to do it all like this, because we've got to still be logical. It doesn't all have to unfold in 60 seconds. So don't get that excited when you're doing it. And yes, in fact, we probably did kill this one. But that means that when this happens in real life, you won't make that error, and you will save the next one. So I don't want you to feel that bad about it. This is why we practice this here. Alright, so Dan,
take the BP on a few.
BP is 70 by 50.
0.5 mg. Sister. Okay, atropine, give atropine. 0.5 mg given. Do you have pain still? Okay, give aspirin 80 mg. Okay, chew it and then swallow it. Okay. Still pain?
BP is 100 by 60.
Okay, give the NCG.
Monitor says 60 beats a minute.
Okay, give, do you have pain still? Okay, give nitroglycerin, keep on the tongue. Okay, one of you start for fibrinolytic, this streptokinase get.
Alright, great. End of this. Thank you very much. Everyone come back.
You give her nitroglycerin, but instead you give morphine, so is that okay?
Well, I think the morphine was a good choice. Morphine can actually sometimes produce a little bradycardia, but morphine when it relieves pain, and morphine also actually reduces lymphatic congestion, so that's another good reason to use it. So I don't think you were wrong to give her the morphine. You have to choke it out and then sped off in that cough in the middle of the nose. And it turns out that you have a pulse. Your pulse is 140. Your blood pressure is 160 by 110. But you are not breathing. You might only breathe one breath a minute, but you're barely breathing. So now I need another volunteer. No, you will be unconscious. I need another volunteer. Who will be the other volunteer? Halfway through, you're going to run in and say, this is Ramesh. We have been looking for him. He is under heroin rehab, and he escaped, and we heard that he bought some heroin and he overdosed. Thank you, Irene, because what we want them to do is check your airway and start to bag you, but because you will have a pulse, they should not start CPR. You only start CPR if there's no pulse. And this is one of the scenarios. And who here has ever seen a person with a heroin overdose? It happens in USA. They tell me it happens here. I don't really know. So if it happens, the person will be in respiratory arrest but still have a pulse. And the antidote, now the antidote isn't even on there. Why don't you give the antidote, which is, does anyone know? Narcan or naloxone. So we'll be giving naloxone. Okay, so everybody says that.
So I'll be searching for her.
You'll be the one who comes in and says, "Thank God you found Ramesh. She's had a heroin overdose." And that's sort of giving them the clue. All right. So this is what we're looking for. If they start CPR, that's a mistake. If they don't handle bag, that's a mistake. So let's all sit down, even our two volunteers. Unresponsive. No breathing.
Ambu. Monitor ECG, oxygen, IV, CPR.
Sinus tachycardia at 140 per minute.
150 per minute.
BP is 160 by 110. Who's bagging?
ECG monitor.
Sinus tachycardia 140. Who's bagging? Are you bagging? If you're bagging, you need to go like this. Both hands.
Monitor.
Sinus tachycardia 130.
What is the reason for the temperature?
Hey. Hello, oh my God, Ramesh is here. She ran away from the rehab center. I guess probably she's heroin overdose. Check her pocket, might be something here. She must be heroin overdose, I'm sure. She ran away from the center. Did you find it?
Still sinus tachycardia 120. Don't stop bagging.
Just doing the oxygen.
It's not breathing.
It's not breathing.
Here's the, why don't you call the pharmacist?
I think she heroin overdose, so why don't you give the overdose antidote of heroin, that is naloxone.
Naloxone, somebody please get with me.
My name's Joe Niemczura. I'm actually a faculty member of the University of Hawaii at Manoa in the School of Nursing and Dental Hygiene. And this is my 4th trip to teach nursing here in the country of Nepal. In the past I've been in a rural area, but this summer I'm actually working at Nepal+Nursing camp. I found that people were very dedicated. They don't have a lot of resources in the area that I was. It was a great little town, but it's sufficiently remote that it's very difficult to find health professionals that want to stay out there, just because a lot of times health professions are really an urban kind of thing. You have the most educated people in the population and they want to be where the action is. The reason I'm here is the LNC that I'm working at is considered to be the best nursing school in the country. And people come here from all over, and I can actually have a much wider impact. The class that I'm teaching on Wednesdays, I have 10 nurses who are teachers, and then I have people from 15 different hospitals in Kathmandu, so I can have a ripple effect outward of the people that I'm teaching, and they will share what they learned with the people that they work with.
And can you explain a little bit about what you were teaching today in today's class?
Well, I'm working on critical care nursing skills. I have 15 years of critical care nursing experience, and one of the issues that we've had has been critical care is fairly new, and we've had what nurses would call this a very functionally oriented education system, because the hospitals are staffed with a minimum number of personnel. So when we're trying to teach people to be critical care nurses, we have to teach them to be very flexible thinkers and make decisions on the spot. And with the Asian cultural influences and the educational system that they've had, what happens is they're not really good improvisers. It's kind of a rote memorization system. And so a lot of what I'm teaching them, what you saw today was a lot of theater. And what I'm talking about them is how you improvise and make decisions within a certain set of parameters so that you can fluidly adjust to rapidly changing patient conditions. It's new for women to be in a professional role. Really within the last 10 years, there's been more acceptance of the idea that women could be wage earners outside the home, that women who are educated can be in healthcare. That's a big change. Women here are actually taught to respect authority, and in the USA when we teach critical care nurses, we actually teach them to respect the facts and to challenge authority when necessary, and that's actually kind of tough. The women that are in nursing right now, especially the ones that I'm dealing with, are ones that have career aspirations, and many of them have decided they're not going to get married or have relationships until they're 28 or 30. And the number of people that kind of put that off is actually surprisingly high among this population group. And actually, an whole generation of young Nepalis, they're very interested in making their way and having like a 15-year plan for, I'm going to do this until I'm 28, then maybe when I'm 30 I'll get married, then I'll have kids when I'm 34. And I actually see that a lot. So I'm not even sure that the idea of how it affects their relationships is even on the radar screen for a lot of these women. Now when you meet them, when you meet some of the ones that are, to me that's really inspiring where they do that. I just got back from 3 days in Bairahua, which is in the Terai. It was 104 degrees there. And I spent time with a lot of people who were from there, who went to Kathmandu+School and returned to Bairahua because they were having that dedication. It's unfortunate to say this, but in many cases these people actually do want to leave the country, and their plan is to go to UK, make a pile of money, and send remittances home. I'm not sure that that's always the most realistic plan, because I think it's not the pot of gold at the end of the rainbow that they think it is, but many times that's their goal, is they see this as their ticket to Australia or India or the UK. And to me that's one of the difficulties, is that we're trying to capture a population of people that are desperately needed in Nepal to be providing health care here to help them with the training.
So with working with so many students, have you had the opportunity to hear some of their success stories or their stories of how they've done nursing in the small villages?
I'm not sure it's a success story, but it's a survival story. And it's a way of saying that you know that what they're doing is important. And my trip to Bairahua, I was teaching there. I was teaching my same critical care stuff there every day. And I got there early one morning, and it was 6 o'clock in the morning. I saw one of my former students from Tansen. She was wearing a blue sari that you couldn't even see her feet. And she had a white lab coat on. And she was the only nurse in the ER that had 20 male patients in it. And it was about 94 degrees out. She was doing all of the stuff, all the nursing care, and going from bed to bed. Now the crazy part was, the way the sari worked, you couldn't actually see her legs move. It was as if she was on a wheeled cart under there. But I actually had this idea, and I know this sounds crazy. Here we were, really hot. Every patient was I have to say, dark-skinned person of Indian extraction living in Nepal. The sheets, there are no sheets on the beds because they get drenched with sweat too quick, and so people lay on the black plastic. She had people from every ethnic group, most of whom didn't have any money. And she was going to bed like she was Florence Nightingale. And that's what I realized at the time was, when I had her as a student, she was very quiet, unassuming. But when I saw her just Tuesday morning, yesterday, she was incredibly professional, reassuring, in control of about 18 patients in a 20-bed unit, and I was proud. Different parts of Nepal have different issues. Bairahua it's in the part they call the Terai. They actually have more tropical diseases. they're more likely to have diarrhea, which is, obviously not so appealing, but dehydration. They actually have, when I was there, we had people who had malaria, various kinds of things like that. Lung disease is a big thing here because so many people cook over wood stoves. The kind of illnesses that you see are very different than you'd see in Western civilization. They had an 11-year civil war, and the first casualty of war is public health. No matter where you go, if you see a stream, you think it's a pristine stream, there is somebody who used the water from that stream uphill. So the first thing is having a better water supply that's reliable. It's a big thing here. The Westerners are all smart enough and wealthy enough to buy processed water or UV filtered water, but people here will drink what's around, and that's just dangerous. The majority of people that actually die of diarrhea are children under the age of 5. I spent the summer of 2008 working on a tropical disease ward at Tansen, the medical ward there. And when I ask people about, I spent 2 months working on a tropical disease ward, I say, what do you think of that? Is that like glamorous? I say, well, that's kind of cool. And what I actually tell them is, no, because what it is it's trying to tell the difference from one kind of diarrhea to another. And it's just so prevalent here. We would frequently admit probably a dozen or more patients a day with dehydration due to diarrhea in that area. We had to tell the difference between AGE, acute gastroenteritis, versus the occasional typhoid or the occasional cholera. Cholera is actually endemic here, and so we always seem to have cases of it around, and so it's important to be able to tell the difference and to be able to isolate that here. Well, the bandas and strikes are not the issue. What we have here is a very medically unsophisticated population that's expecting medical sophistication, and when they don't get it, the typical way of expressing their displeasure is, and I'm sorry to say this, but many times the health professionals who are providing it are attacked or challenged or threatened. And actually this is one of the things I'm working on while I'm here is how do people deal with the idea that they're trying to resuscitate a patient while the cultural practice is for the grieving family to demonstrably express their grief at the same time. And very frequently in the news here you read about something where the person died and then the family attacked the doctors or nurses, and that's the challenging situation we have. I've been asked in every place I've been, what's my opinion, how are we going to fix that? Like everything else, I don't have the answers if these people don't have the answers. If things aren't working for them, it's not because they're not intelligent or that they haven't put effort into figuring things out. It's that the challenges are big. And so actually, I work with them on how we deal with that so that we're, in a controlled situation and can do the resuscitation. But the cultural practice here is that if a person is sick, every living family member, as soon as they hear about it, makes a beeline to the hospital. I've sometimes joked about it and said, it's like Woodstock. You come in and you know that someone's sick because every surface on the floor has got a blanket and a relative sitting nearby, and it just gets out of control sometimes. On the one hand, it's a unique and wonderful cultural thing that people support each other, and the daily experience with illness and death here is very different than you would have in Western civilization where we isolate it. It's close here. We often have the discussion, is life cheap in Nepal or is it more precious? I don't actually think it's cheap. I actually think it's more precious because it's fleeting. The number of ways that, the illnesses and the life expectancy challenges here, people have a very different daily experience of illness and death than you would have in Western society.